Hello, everyone. Welcome to the Association Between Mental Disorders and Productivity and Interventions to Improve Disability Outcomes webinar. We're glad to have you here with us today. This webinar is part of our Return to Work, Stay at Work series, and we're glad to have you here today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Grants Program through the BC government, as well as through donations and memberships to CIRPD. As I mentioned, my name is Tanya, and I'll be moderating the session and handling the Q&A today. And our speaker today is Carolyn Dewa. Dr. Dewa is a collaborating scientist at the Center for Addiction and Mental Health. She is a leader in workplace mental health research, particularly in disability related to mental illness among workers, the effects of mental illness on productivity, and interventions to improve disability outcomes. Her awards include a Canadian Institutes of Health and Research, Public Health Agency of Canada Applied Public Health Chair for her research in mental illness in the working population. She's also received a Career Scientist Award from the Ontario Ministry of Health and Long-Term Care. Thank you very much for being with us today, Carolyn, and I will hand it over to you.
Thank you. So thank you everyone for joining us, and I'd like to thank the Canadian Institute for the Relief of Pain and Disability for the opportunity to talk with you folks. So we're going to talk today about the association between mental disorders and productivity and interventions and how to improve disability outcomes. So I was in Canada, and I just recently moved down to University of California, Davis, but before I begin, I'd really like to acknowledge the folks that have contributed to this research. So the Ontario Ministry of Health and Long-Term Care Career Scientist Award, the Ontario Roundtable on Appropriate Prescribing, the Canadian Institutes of Health Research, and the Public Health Agency of Canada Applied Public Health Chair. But most of all, I'd like to thank the workplaces and the workers who volunteered to participate in the research and to share their experiences to help our knowledge about improving mental health in the workplace. So this presentation is divided into 3 parts, and there are 3 main learning objectives. So at the end of the presentation, hopefully, participants will be able to discuss the factors that are related to the cost of mental illness in the workplace, identify what to target in the workplace to reduce costs, and to explain the types of interventions that can reduce costs. Back about 6 years ago, we did a study to look at the costs of mental illness on the Canadian economy. And it was interesting because it got a lot of attention because it was about 10 years ago that people started really paying attention to the impact of mental illness. And so the things that contribute to the costs are the treatments, the medical bills, but also disability and sick leaves. And these account for about half of the cost of the $51 billion. So let's talk about the factors that are related to the costs of mental illness. How do we decrease these costs? Well, one of the things that I first started thinking about was, well, really, what's the prevalence? How many people in the workplace are affected by mental illness? So using the Canadian Community Health Survey, which is a population-based survey, and we're looking at workers in Canada, we looked to see what proportion of these workers experience a mental disorder. And what we found was about 3% experience a mental disorder only, without any other condition, in a 30-day period during a month's time. It was more likely for people who were experiencing mental disorder to have another condition and associate with it at the same time. So about 3% also had a chronic physical condition, and about 2% had experienced chronic work stress. Now, chronic work stress was defined as most days that you go to work as being really extremely stressful. And about 3% experienced all 3. mental disorder, chronic work stress, and a physical condition. And it's so in total, it's about 11% of the workers in the workplace experience a mental disorder, but most of them are experiencing it in combination with other types of conditions. So, well, how does that impact the workplace? Well, we wanted to know, and we looked at 3 different types of disabilities that might impact the workplace. So there was the total disability days, and this is the square, and those are what you might call sick days or sick leave days, where people aren't coming into work at all. And we also looked at partial disability days, which is this empty circle in the middle, generally the middle bar. And these are days that people come into work, but they're not able to do as much as they normally do. And you often hear these referred to as presenteeism days. And then we also looked at extra effort days, and these are the solid circles. And these extra effort days are days where somebody can come into work, they can get their job done, but it takes an extreme amount of effort. It's those types of days where after the end of the workday and you go home and you drag yourself to the door and you kind of plop yourself down on the couch and you can't move the rest of the evening because you're so exhausted. And those are the types of what we're talking about. We're talking about extra effort days. Now, the way that we looked at it, we looked at odds ratios. So odds ratios are used to describe the risk. So oftentimes, if you've ever gone to a racetrack and you hear about the odds placed on a horse winning, so if you have 2-to-1 odds, you know that you're more likely, the horse is more likely to win. In the same way, when we talk about the odds ratios, if you have an odds ratio of 1, you're as likely to have it as not. So when we look at chronic work stress, we see that it's very close. The odds are 1-to-1 that you are going to have any type of disability day. But when you look at when you have a psychiatric disorder, your odds increase. You're more likely to have any of these types of disability days. And as you move out along with the different combinations of conditions, chronic work stress, physical condition, or having all 3, your odds increase with each, depending on the type of condition. And when you have all 3, for example, you're more likely to have any of these types of disability days. So one of the things that we've been studying and most because of its impact on the workplace is the short-term disability absence. Now, interestingly, when you're talking, and these would be captured in that total disability days, the absence from work days. Interestingly, the criteria for these are based on the insurance policy. So it could differ for each company depending on the insurance policy that the company has for short-term disability benefits. The criteria assumes that the workers met a predetermined threshold that requires a prolonged absence from work, but there's no real universal criteria. So we see this definition of short-term disability as really a reflection of what it was developed for injuries at work. So, for example, if you had a broken arm, you knew when you needed more time to heal to come back to work. It gets a little bit more difficult when you don't have a physical diagnosis in terms of a test to determine when somebody needs to be off of work or having a threshold. But when we look at short-term disability incidents, so we looked at one company in Ontario with sites all over the province, there were about 15 episodes in total per 100 workers. The top 5 causes for these disability episodes were respiratory disease, mental, behavioral disorders, injury, musculoskeletal disorders, and digestive disorders. Now, interestingly, when you look at respiratory, it's about 2.3 per 100 workers, and for mental disorders, about 2.1 per 100 workers. There's not really a huge difference between the respiratory in terms of the episodes. So there's a huge difference between respiratory, mental disorder, and injury, and musculoskeletal. And even though, as I was saying, that there's no universal criteria, when you look across the literature, so we did a systematic review to see how what was the rates of disability. You can see that in the literature there's consistency, no matter from the Netherlands, Canada, it's our study, and Norway. Those were the three main studies that we saw in terms of the rates of disability. Now, the length of the episodes, on average, a disability episode would last for about 33 days. Respiratory disorders is about 10 days, but for mental and behavioral disorders, the episodes would last about 67 days. So we see that it's double the average length of the day, length of the episode. And again, we look to literature to see if this was an anomaly, and one of the places that we found where there was reports about the length of the disability, it was from the Netherlands. And it's interesting because the Netherlands is why the Netherlands keeps popping up, and part of it is because they're one of the leaders in the area of this type of research, and they've spent a lot of time focusing on disabilities. And so we're not that different in terms of the length of the disability. Now, given the length of the disability, you would also expect the differences in costs. So the average cost for a disability episode was about $9,000. Not surprisingly, because the length of the disability for mental behavioral disorders was twice as long as the average, we also see that the cost is about $18,000, almost double that for the average. So what do we see? We see that part of the reason that the mental disorders, the high cost, is that it is associated with disability days, and those disability days often there are also often more of them when they occur. So what would you target in the workplace to reduce costs? There's so many things that we could possibly do. What is the most efficient use of our resources, and where would we go? Well, if you go to the literature, we went to the literature and did a systematic review, and to understand and identify what the best practice guideline recommendations were from around the world. Now, one of the limitations of our search was that we focused on English language types of best practices, and we saw that they were coming out. There were three main ones that we identified from Canada, the UK, and Australia. And the things that were identified as best practices for employers was return to work is coordinated and planned, that there would be work accommodation, that there would be access to mental health treatment, that leave is coordinated, and there would be an assessment of disability. Now, the interesting thing in Canada, the UK, and Australia, that there was an emphasis on access to mental health treatment, because each of these systems are publicly funded systems. So the question comes up, so how can people not have access to mental health treatment? Are there barriers to treatment? Because that's what it seems to apply. And if you're from the economics perspective, there are at least two main barriers that people could be encountering when they're seeking treatment. One is the out-of-pocket costs. The price could be a barrier for them to accessing care, or a lack of experience or taste could be a barrier. So one of the things that we're wondering is, what do we mean by out-of-pocket costs if it's a publicly funded system? Well, in the Canadian system, one of the things that is not covered usually by the public system is prescription drug costs. It is covered usually for seniors and for people who are financially disadvantaged, but for the bulk of the population, it's not. And oftentimes it's covered. If you have a large company and you're fortunate, you will be covered with the supplemental benefits. Now, most of the time when you have a supplemental benefit, there's also a copayment. So there's an out-of-pocket cost contribution when you go to fill a prescription, even though you do have insurance for it. So the interesting thing that we wanted to know is, well, when you go on to short-term disability, oftentimes your income replacement is not at 100%. That is, you don't get 100% of what you would normally earn when you're on disability, and oftentimes it's percentage, so 75%, 65% of what your normal income is. At the same time, the co-payments that's required for your prescription drugs don't change. So you're responsible for the co-pays, but at the same time, if you're on short-term disability, you often have less income to pay for it. So what does that do? So we looked at antidepressant use for those who are on short-term disability and the days until they actually filled the prescription for an antidepressant. Why did we look at antidepressants? Part of the reason is because guideline treatment talks about the use of antidepressants, and so why are we looking at days until fill? Because oftentimes when people don't fill their prescriptions, and one way of managing costs is to delay the use of the prescription. So we wanted to know if that was in truth the case. The other thing is that we found that the people who were going on to short-term disability for depression were also had chronic physical conditions that they needed medication to treat. And that's about 50% of them. And so heart disease, respiratory hypertension. So these people had to fill prescriptions for chronic conditions even before they went on to short-term disability. And now they were given antidepressant script to fill. So what did we see? We saw, and this is the navy blue line, that the people who had higher out-of-pocket costs and that they had more they had to pay more out-of-pocket for chronic physical conditions in addition to their antidepressants, took longer to fill their antidepressant script. And those who had lower out-of-pocket costs for other prescriptions took a shorter time to fill their antidepressant script. So we see, why is this important? Well, because we've also seen in another study that if people who had early treatment in their disability episode, they were more likely to come back sooner. So if a worker got treatment within the first 30 days, you would see a decrease in their episode of about 3 weeks. And no matter how we modeled it and played around with the data, that was a robust finding. So the early intervention, the early treatment is important, and yet if people are not able to or not filling their scripts early in their short-term disability episode, that could present a problem to them returning to work sooner. Another thing that we were wondering was, okay, so is there another reason why people might not get treatment? So we did a survey of about 2,000 workers in Ontario, and we wanted to know what they would do if they had a needed treatment. So we used a standardized scale to see if they were at risk of having depression and whether their symptoms were severe enough that they might benefit from getting help. Well, in the survey, we found about 38% might benefit from getting help. And of those who needed help, could benefit from help, we found that about 52%, 53% didn't recognize that they could benefit from help, didn't recognize a need for help. So that was one of the barriers to accessing treatment. It's potentially people don't recognize that they need help. And of those who did recognize their need for help, there were about 12% who said that they wouldn't go seek help. And part of the reason was attributed to, well, they didn't think that treatment would work, or they didn't want anybody to see that they were getting treatment, that they thought they could just get through it, and rather than seeking help. So that was an attitudinal barrier that also potentially helped prevent people from getting treatment. And then there's the structural barriers. So of those who didn't have an attitudinal barrier, about 9% faced a structural barrier. So a structural barrier means that they couldn't afford the out-of-pocket costs, they couldn't afford the time to go and seek help or treatment, or they couldn't take time off of work to do it, to get treatment. Because oftentimes treatment's not offered during off-work hours. So to seek help and to see a clinician, you would have to take time off of work. And they felt that they weren't able to do it. Of those who had an attitudinal barrier, about 21% also had faced a structural barrier. So are there barriers to treatment? Yes, it seems that the out-of-pocket costs or the price are a barrier, and there's also attitudes and tastes that influence whether people seek treatment. So what kind of, given that that there are factors that are identifiable that prevent people from seeking treatment, what types of interventions might be used to address the costs? How do we address the barriers to accessing care? Well, when we asked the workers, 35% of them said that we asked them, because you need to oftentimes leave work to be able to get treatment, so you have to take time off of work. You often have to explain to your manager that you're going to get treatment, and we asked them, workers, how many of you would disclose to your manager, and what factors would depend upon it? Well, 35% said it would depend on a combination of factors: the relationship with your manager, whether you had supportive colleagues, or your organizational policies. And 26% said it would depend on all three of these, plus having seen other people have positive experiences. So there's also a contribution of what the workplace and the work environment contributes to helping and supporting someone make the decision to seek care. 39% of the workers wouldn't tell their current manager that they were experiencing mental illness, and part of the reason was why? Because they were afraid for their career. Or there were those who seen others have bad experiences in their company when people knew that they had a mental illness. They didn't want to lose their friends because people became afraid of them because they had a mental illness. Or there were a proportion who thought it wouldn't impact my work, so no one would notice that, and my work wouldn't suffer. So one of the things that we wanted to know, well, what if we were able to educate people within the organization about, well, how to recognize when help could be needed for a mental health problem, and help people understand what type of help is effective, and that where to access that help, or address those barriers like getting time off of work to be able to access treatment and help. So oftentimes companies aren't able to do everything at once, and if they wanted to phase in different types of interventions or educational programs, we wondered what would you start with? Well, we looked at that in terms of productivity loss, because we know that mental illness is associated with a decrease in productivity. So what we want to do is to prevent that loss in productivity. So if you did nothing and you didn't address any of these barriers, the attitudes, the recognition of need, the system barriers, you would still have 100% of productivity loss. But if you only wanted to address one of the barriers, where would you have the biggest impact? Well, if you first address the recognition of need and you were left with the attitudinal and the system barriers, you could decrease the losses from productivity by about 10%. Well, after you do that, and then you want to address another barrier, one of the things that you see the biggest impact on decreasing productivity loss is to address the attitudinal barrier, where you're only left with the system barrier. And if you wanted to decrease the loss from productivity the most, you would address all three, and you could decrease productivity losses by 50%. So this is another way of looking at it. So first, removing the recognition barrier, it has an impact of about 10%. Then removing the attitudinal barrier, and then moving the financial barrier or the structural barriers. So oftentimes organizations ask, so okay, if I do that, what kind of return do I need to see, or what kind of outcomes do I need to see to show the effectiveness of the program? Well, one of the things we wondered is, okay, what if a company wanted to break even? That is, when would a program pay for itself? So in our model, we assumed that there was a company of about 1,000 people, that about 100 managers. Each of the managers went to one whole day of training. Now, when they have the whole day of training, that's all your managers not at work and no one actually doing their work, so there is a cost to the company of doing that and a cost of the training. So when would that training pay for itself? Well, one way, if nothing else happened, but you decreased the number of episodes in the company by 2 episodes for a year, that would pay for the cost of the training. Or if you didn't decrease any of the episodes at all, but you were able to decrease the length of the episodes by about 7 days, that would also pay for itself. Now, is 7 days a realistic figure? Well, remember, early intervention, early treatment could decrease the length of a short-term disability episode by about 3 weeks. So if people are able and do access early treatment, we could see a decrease in the length of the episode because they're able to return to work and recover sooner. Now, another thing that we've been thinking about, and remember during the first slides where we looked at the effects of the types of disability on the workplace, and one of them was extra effort days. Well, we've been looking at the concept of high need for recovery. That is, when workers are putting in a lot of effort and energy into work but don't actually have enough time to recover from that expenditure of energy and effort, what happens with their productivity? And so we looked at productivity in terms of 4 different characteristics of productivity. There's time management, there's ability to handle physical demands, there's ability to handle mental and interpersonal demands, and output demands. What do we find? That the percent of productivity loss related to time management increases by 8% when you have a high need for recovery, and that people aren't recovering from the efforts that they put in. It's about 4% greater for productivity loss related to decreased physical demands. There's a 5% increase in productivity loss due to mental failure to be able to handle the mental interpersonal demands, and about 6% increased loss in terms of output demands. So these are also things that the literature has been talking about, how companies could be able to, another way of improving or addressing the losses when people suffer from experience mental health problems in terms of having extra effort and helping them, giving them the opportunity to recover. And it's interesting because the recovery time, it's not always a huge effort. Sometimes it's just allowing people to have micro breaks in terms of in what they're doing during the day, so that they're able to recover from if they're having very focused concentration and a lot of effort focused on that, just taking a walk sometimes, or switching tasks for a little bit, or in terms of things, if you think about your workers who are always putting in overtime or working on the weekends, do they have an opportunity to recover, and remembering that they too could increase their productivity really if they had an opportunity to recover. So in terms of what we covered today, what we found were workplaces incur significant costs for mental disorder-related work disability, and part of the cost can be addressed by addressing stigma in terms of the barriers that we're recognizing the need, the attitudes, and the structural barriers. And by addressing stigma, disability costs could decrease, so organizations could see a return through decreased sickness absences. So that's, I think we'll stop here, and if there are any questions, I'd be happy to discuss them with you now.
Wonderful. Thank you very much for that, Carolyn. Very good presentation. We do have a couple questions already. I encourage those of you online, if you have questions, to go ahead and type them into the question box. First question is, in your study, did you look at access to mental health care, i.e. wait times for covered care, allied health, like psychologists not covered in Ontario?
So in that study, we didn't look at the wait times. However, in another study, we looked at collaborative care in terms of where oftentimes it's the primary care physician who's providing care, and people don't necessarily see a specialist. So in the study, we evaluated a model where a psychiatrist offered to provide consultation to the primary care physician if they wanted it, and if the worker was in agreement with it. And we found that it significantly decreased the length of the disability episode, and people were more likely to come back to work, and it was less costly because the primary care provider was more confident in their diagnosis and their treatment plan.
Great. And then another one, someone was asking for clarification on the statement you made about the tastes as a factor.
So it's a jargon that we use as economists. When we talk about taste, it's another word for their preferences or their view of the world. So if you were doing an economics model, you would put the stigma and recognition maybe into a very broad category called taste, and it just means preferences.
Okay. Someone asking, how do you recommend addressing the stigma of mental health in the workplace?
So part of the Mental Health Commission of Canada has been doing a lot of work on this in terms of their Opening Minds project in addressing stigma, and part of it, the success has been in helping people understand what mental illness is and kind of and having people understand that actually everybody at different points experiences these symptoms, and it's really a continuum of being healthy to needing severe experiencing severe symptoms, and so part of it is helping people understand what mental illness slash mental health is, and understanding that it's not just other people who experience it, but we all experience it. And so educating people on recognizing when treatment could be beneficial and when they could use some help. And sometimes the help is self-help or self-care types of interventions, and helping managers understand what mental illness is and how to manage people, and not be afraid of being supportive, and teaching coworkers on how to be supportive, because also in our studies we found that people are often don't do anything because they're afraid of making it worse, but helping people overcome that fear and understand that they can help and what they can do to help.
Great. Someone asking, what type of industry was your study based on? And did you see any difference between firms that require more cognitive function, like corporate places, versus places with more physical manufacturing or shift work?
Yeah, so the company that we looked at when I talked about the disability rates was an energy company, but we looked within the company, so there are all occupations represented within the company. When we looked at productivity losses, it's interesting. Let me see. When you look at mental health, when you look at the types of productivity losses, when you have poor mental health, it's significant depending, and so this piece of the sample, there was a lot of managers and there was a lot of people who weren't doing a lot of physical labor, that we saw that the productivity losses were more significant for the time management and the interpersonal and the output demands, but there was less for the physical demands, and that was part of it, was a reflection of the types of occupations that we're seeing.
Okay. Someone asking, in highly managed projects, each resource or worker is tracked in terms of productivity, so they can assess the impact of a productivity loss. But a lot of employment roles don't measure that formally, and especially in the case of small businesses. And a person's asking, how do they encourage them to output the upfront costs for training if they're not actually tracking productivity loss to see that as a benefit?
It's interesting because in other studies we've seen that if you're in a smaller workplace, oftentimes the manager is more familiar with the workers, and so it's not necessarily, and I've been thinking about this, it's not necessarily about how many things you get done, because there's also should be a quality adjustment to it too. So not only how much you get done, but how well you get that done, and that's still a challenge because I don't think we measured that very well either. And so it's a question that we're still struggling with. So I'm sorry, at this point we don't have, I can't give you a really great answer.
All right. And let's see. Someone's saying, if they read the last table correctly, it appears you focused on need for recovery as it had the greatest impact on work productivity loss. But it appears that high work satisfaction had a much bigger impact on increasing work productivity.
Yes. And we also see that if you have high work satisfaction, you're also, it's associated with having being more mentally healthy or having a higher mental health status, so that work satisfaction and all of that goes into contributing the health to work satisfaction is a very important criteria for productivity and well-being and mental health.
Great. What should individuals who are not able, what should individuals do who are not able to get access to specialized care, i.e. psychiatrists, due to financial burdens and they have trouble getting access to pharmaceuticals and that sort of thing?
That is a challenge. Part of it may be going to the community mental health centers to see if help is available, because there are counselors there that can help. That it is a challenge, and that financial barrier is a problem for folks that don't have insurance.
Yeah, that's definitely an issue. Do you know if there is discussion in the newest mental health guidelines about making mental health more of a priority for extended insurance?
So when we talk about the return to work, the guidelines, the best practice guidelines, it speaks to employers to help employees access mental health services, and part of that is making sure that what's not covered but by public insurance is accessible somehow to their employees.
Mm-hmm. Very good. Let's see. I think that might be all of our questions at the moment. We can give it just a moment, just in case anybody else has a question. There have been a couple of questions from people just asking if the PowerPoint is going to be made available, and it will. Carolyn said that it would be fine if we posted a copy of it, so that a link to that will be sent out along with a link to the recording. Hopefully early next week. It should be Monday or Tuesday. Let's see, and I think that might be everything. Thank you very much, Carolyn, for the presentation. So much information and super interesting, and I'm looking forward to seeing more of what your research brings to light on these topics.
Thank you very much for the opportunity and for everyone's questions and their interest. It was great.
Wonderful.